afternoon. My name is Dr. Tracy Newman, and I'm a pediatrician and the medical director here at the North Dakota State University Center for Immunization Research and Education, easier known as CIRI. Today, I have the pleasure to introduce Dr. Kristen Panthagani, who will be presenting this webinar titled Vaccine Communication in an Age of Polarization. Dr. Panthagani is a Yale emergency scholar focusing on health literacy and communication. She writes the newsletter You Can Know Things and is a contributing writer for the internationally renowned public health newsletter Your Local Epidemiologist. Her writing focuses on addressing public health rumors and has reached millions worldwide with features in the Wall Street Journal, New York Times, Forbes, and numerous other prominent outlets. Dr. Panthagani earned her PhD in genetics and genomics from Baylor College of Medicine, studying the human microbiome, and is currently a fourth-year resident in Yale's combined emergency medicine residency and research fellowship. Dr. Panthagani, welcome. You may begin.
Thank you so much for that introduction, and thank you for having me. I'm really excited to be here. Let's get started. All right, starting with disclosures, I have no relevant financial relationships to disclose. And our learning objectives for today discuss the roles of misinformation versus miscommunication in driving vaccine hesitancy, recognize miscommunication and messaging failures during the COVID pandemic and how they contributed to vaccine hesitancy, and identify productive and counterproductive responses to individuals who are vaccine hesitant. Give me just 1 second. I'm going to minimize something so I can see better. Okay. All right, so those were the official approved learning objectives. Here's my unofficial, more informal learning objectives. Is that by the end of this talk, I'm hoping to help encourage and establish empathy for people who are hesitant about vaccines, and that you'll see there were valid reasons that people became confused during the pandemic, and then learn some tips for communicating about vaccines with clarity and empathy. So first, just a brief introduction of who am I and how did I get here? So this is a Facebook post from March 10th of 2020. At the time, I was in my last year of my PhD training at Baylor College of Medicine. And like many of you on this call, I was very distracted from my day job and looking at the emergence of the COVID data. I think at the time, the best available public data was a crowdsourced Google Sheet. And I started making these graphs comparing the US to Italy and posting them on Facebook. And what I found is there was a huge need for this type of communication. And so I kept going. And starting with my personal Facebook account, I kept making posts and I made fancier graphs. And then, as we all know, there was the emergence of a bunch of interesting and creative viral rumors about COVID. And so I started writing about those. And as I was doing this, one, I recognized that there was a huge need. But two, I kept asking myself, why can't people find answers? And why are they turning to their grad student friend on Facebook? So recognizing this need, I started a website called You Can Know Things. And the website I continue to this day. It's now on Substack as well. And I started writing primarily about the rumors. So, I'm sure many of these you remember all of the controversy over masks, the idea that COVID vaccines will sterilize women, everything about hydroxychloroquine. So this was my focus for a long time, was addressing these rumors. And that's something I still do today. But as I went through this for about the first 2 years of the pandemic, I started to notice there was a big disconnect. There was a disconnect between the scientific community and the public, and what the scientific community was saying and what the public was hearing. So here's just a few examples. So this was something we would commonly see: the COVID vaccines work, stop spreading misinformation. But I was hearing in my comment section, didn't you all say the vaccines were 100% effective? Clearly they're not. And then this we still see all the time: mis and disinformation are the problem. That's why people don't trust vaccines. But I had people close to me saying things like, even using the word misinformation will turn a lot of people off from listening to you. And then this was another one that showed up in news articles. They don't even understand what vaccines are. You can't help the COVIDiots. We'll talk about that misunderstanding of the definition of vaccines in a little bit. And then you had people saying, okay, I thought vaccines gave us immunity, So why are so many vaccinated people getting COVID? Confusion over what immunity actually means. And then I feel like every single social media website for a while referred everyone to the CDC website. But on the other hand, I saw my friends in the town I grew up in sharing these viral rumors, not because they knew it was true or they even thought it was true, but because they were mad that these videos were being taken down off of YouTube. So there was a big disconnect between the messaging from the scientific community and the concerns and confusion and values for many in the public. And I think that's a big reason why we are where we are today. So how did we get here? This is just, I wanted to do a brief look at some of the factors contributing to vaccine hesitancy that I think sometimes get overlooked. So the first thing to remember is that vaccine hesitancy is of course not new. This is from 1892, and if you look back at that time, they were dealing with many of the same things we're dealing with today. That's a general distrust in medicine, a suspicion the vaccines didn't work, and with the introduction of vaccine mandates, objection to violation of personal liberty. And this is a film from 1982 showing distrust in the DPT vaccine. And of course, we all know this very infamous article in The Lancet in 1998 alleging a link between the MMR vaccine and autism. So this is not a new problem, but it feels like it's going into overdrive now. And there's a couple cultural factors that have been brewing over the last several decades that are contributing to this. So one that I think is often overlooked is the hygiene hypothesis. And this was a hypothesis in 1989 that infections were associated with a decreased risk of allergies. And of course, the further research showed it was much more complex than that. And it was actually more the beneficial bacteria in the microbiome that were likely the link. However, this led to a common belief that infections and germs are actually necessary and good for kids. And so that's a rumor still see circulating, is it's bad if kids don't get their exposure to viruses. Of course, we have all the wellness and natural marketing, which kind of burns this narrative into our brains, the appeal to nature fallacy that natural must be better and synthetic must be bad. We also have the problem that health information is provided often in a way that's too complicated versus misinformation is often explained in a very easy to understand way. So this was a study that looked at health information across different sources on the internet. And it's recommended that health information for a patient, at least patient-facing information, be provided at the 6th grade reading level. But overall, the average is much higher. It's the 10th to 12th grade reading level. Now, of course, this doesn't mean that everything we write about any health topic should be at the 6th grade level, but it does mean that we're probably missing a lot of people who need the information provided in a simpler way. We know that our healthcare system is in many ways broken, and for many people, their loss of trust in modern medicine starts with a bad experience in the healthcare system, and then later spreads to things like vaccines. And of course, we know that vaccines in many ways are a victim of their own success. People have forgotten the diseases because we've so effectively suppressed them. And then finally, we know misinformation is very profitable through many ways. Supplements is one way that people can say, you know, you don't really need the measles vaccine. I have a supplement you can take instead. And I know, at least I thought this, and I heard it commonly said before COVID, is that once there's a pandemic, then people will see the value of vaccination. And one of my absolute favorite movies is Contagion. And it's sad rewatching it. At the end of that movie, it ends with the vaccine saving everyone. And clearly that's not quite how it played out in real life. So we know that COVID vaccines have saved millions of lives. And this is just one model that estimates in the first year it prevented, or the first year that vaccines were available, it prevented 20 million deaths. Yet after the pandemic, trust in vaccines declined significantly. So in this graph, this is from 2023, you can see the change in the percentage of people who perceive vaccines as important for children before and after the pandemic. On the x-axis, we have countries, and on the y-axis, blue is an increase in the perception that they're important, and gray is a decrease. In the vast majority of countries, it went down. This is some more recent data. So this is from August of 2024. And it shows over the last 2 decades, Americans are less likely to say it is important for parents to have vaccinated their children. The blue line is those who say it's extremely or very important, and the green is extremely important. And then this is from this summer, July through August of 2025. And we see that many parents express doubt over childhood vaccine recommendations and safety. So the percent of parents who say vaccines do not go through enough safety testing before being recommended for kids is 35% of parents. And 26% of parents say the CDC recommends too many vaccines. So a lot of people, when they see this data, they say, okay, misinformation is the problem. There's so many lies and rumors and falsehoods about vaccines, and that's why we've lost trust. And there's certainly some truth to that. Certainly a lot of truth to that. So this is data from 2023 looking at the prevalence of belief in false claims about COVID vaccines. And the one that just absolutely blows my mind is that 1 in 3 Americans believe COVID vaccines have killed thousands of people. 1 in 3 Americans say that claim is definitely or probably true. That is a giant chunk of the population. And this is what I spent a whole bunch of my time over the last 5 years writing about, was all these rumors and myths. And while I fully acknowledge it's a giant, giant problem, I don't think it's the only problem. So what I saw over the last 5 years, in particular during the first year and 2 of the COVID vaccines, is that sometimes what we were calling misinformation was really miscommunication. So some definitions for you. Misinformation is the dissemination of false information, either knowingly, which we call disinformation, or unknowingly. While miscommunication is any message or series of messages where the preferred meaning is misinterpreted by the target audience. So here's sort of an imaginary example pulled from years of reading comments and looking at what people are posting online. So starting with public health. Vaccination will give you immunity against COVID. Public, great, so I won't get COVID? Yep, it's 100% effective against severe disease and death. Awesome. All right, so we have buy-in. Then a little while later, Delta hits, and people who were vaccinated started dying. And the public is saying, my mom died of COVID and she was vaccinated. We say, okay, well, there's a new variant, but the vaccines are still highly effective. But more vaccinated people are dying than unvaccinated, which at the time was true. And then we say, oh, that's the base rate fallacy. And they say, what? I find the base rate fallacy is one of the hardest things to explain simply to the public. It's a very challenging concept. So I would call this all miscommunication. People, public health trying to communicate what's going on, but the messages are either overly simple or aren't explaining the full range of nuance, or it's a complicated concept that's just not being explained effectively. But a lot of this got labeled as misinformation. But this kind of sets the stage for the public to say, or I'm sorry, for the public to believe this message that comes along that says, hey, they're lying to you. The vaccines actually increase risk of death. They'll say, yeah, none of this makes sense. They're confused. And this is mis and disinformation. So with that in mind, here's my top 5 lessons learned addressing rumors and myths during the pandemic. And these are more focusing on the communication issues and communication failures on the public health side. And the goal is to learn from hindsight we have now, certainly not to blame communicators for mistakes they didn't see coming. Communication during the pandemic was extremely hard, and my goal is not to beat anyone up or have anyone beat themselves up, but instead learn so we can do better. So lesson number 1 is to set expectations. So here's just a brief trip down memory lane for you. This was June of 2020. This is when the FDA announced what their bar would be for efficacy for the COVID vaccines for it to be considered for FDA authorization. And the bar was 50% efficacy. So of course, all the pharmaceutical companies working on this and the scientists very focused on this read this headline and they had their expectations set. But at the time, there was so much other news going on that this barely made a blip in the headlines for the majority of the public. Most people did not see that that was the bar of what we would consider a successful COVID vaccine. 6 months later, that's when this really started to hit the news. So this was in December of 2020 when we started to get the press releases on the phase 3 data. And of course, we got headlines like this: Moderna reports 100% vaccine efficacy against severe COVID. And this is predominantly what set people's expectations about how well the vaccines worked, was these headlines. And this became a common talking point that all 3 COVID vaccines were 100% effective at preventing severe disease and death. And of course, if you remember at the time, we had so much opposition to the vaccines and so many lies and falsehoods that were circulating. And then we also had people who were wanting to wait to get their favorite vaccine based on the efficacy against symptomatic infection. So the goal of this messaging was to remind everybody, like, hey, all 3 vaccines are really good. Like, don't wait 2 months to get your favorite one, get the first one you can, which of course was a very well-intentioned message. But in hindsight, telling the public that vaccines are 100% 100% effective set people up to think they were perfect. And of course they were not. So this was the expectation. If you get the vaccine, you won't get COVID. And that's not what happened. So of course, Delta came and we started getting breakthrough infections. And then there was boosters. And then of course we had new variants and surge after surge. And so this is how a lot of people started feeling, is that they were told it was a 100% effective vaccine. And of course, that was against severe disease and death, not symptomatic infection, but getting cohesive messaging over clinical endpoints is pretty challenging, and a lot of people mix those up. So that was their expectation. And then all of a sudden the messaging changed to, why did you expect a perfect vaccine? Vaccines aren't perfect. Stop spreading misinformation. That is how a lot of people responded. And you can understand how that made people potentially feel kind of gaslit by the public health messaging. So the lessons learned is, don't promise 100%. It's a promise we can rarely keep. And to communicate uncertainty, especially with early data. If we had put out messaging that said something like highly effective, even that would have been better than 100%. And I think part of the messaging was motivated by all the negative press and not press, but the negative pressure against the vaccines, and that there were so many people who were hesitant and all of the rumors and falsehoods. And so I think there was a fear to acknowledge that there may be any weakness in the vaccines to some degree. And that's just setting ourselves up for failure. So don't be afraid to say that vaccines aren't perfect when they're not perfect. All right, so we're going to pause here for a knowledge check. So if we could go back in time, which headline would better set expectations about the effectiveness of the COVID vaccines? So imagine these as headlines in the news article that people are reading. A, the results are in, the COVID vaccines work. B, clinical trials show the COVID vaccines are highly effective. C, COVID vaccines significantly reduce the risk of hospitalization and death. And D, the vaccines stop COVID. Get the first one you can. Give you a second to think about it. All right, I would pick this one. Of course, there's a little bit of subjectivity to these headlines, but I would say C is the one that most clearly explains that it reduces the risk, but doesn't eliminate the risk. I think you could argue for B, that they're highly effective. I just suggested that like 2 minutes ago. But the word reduce, I think, is the ideal word to use, because it explains, that there is an effect, but it's not perfect. It's a reduction. All right, lesson number 2. Words confuse people. Speaking of the word reduce and works. So I don't know how many of you remember this rumor that was circulating, I think it was either 2021 or 2022, that the COVID vaccines aren't actually vaccines. And this was another thing that was labeled as, this is just misinformation, and people don't know what vaccines are, and people don't know what they're talking about, and they're uneducated. That was how a lot of people responded to this rumor. But if you dug into it, this is why people were saying that. So they pointed to a change in the definition of vaccine on, I believe it was the CDC website. And the old definition was a vaccine is a product that stimulates a person's immune response to produce immunity to a specific disease, protecting the person from that disease. The new definition is a preparation that is used to stimulate the body's immune response against a disease. Now, to I'm sure all of you, those sound like identical definitions. But to a lot of people, this was a critical change because the word immunity was eliminated from the definition. So to understand why that was such a big deal to people, we need to go back to think about how people interpret the word immunity. So a lot of people think immunity is like an on and off switch. And this is understandable if you think about the colloquial definition of like legal immunity, or even how immunity is portrayed like on TV. It's kind of an on or off of either you're immune or you're not. And sometimes when we explain how childhood vaccines work, that simplified version is what we tell them. And I did an informal poll of what people think the word immunity means, and this was my favorite answer. Immunity is like in the zombie movies where the zombies can't get you. It's a yes or no answer. You're either protected or you're not. And of course, we know immunity is far more complicated than that, involving multiple very complex systems, and that it's not simply an on or off switch, but there's such a thing as kind of partial protection. But for a lot of people, what they had learned about childhood vaccines and what they had learned about the word immunity was if you get a vaccine, you get immunity and you're not going to catch it. So if vaccinated people are catching COVID, they deduced these must not actually be vaccines. And this belief was bolstered by the removal of that word immunity from the definition. There's other words that I saw confuse people over and over again. So one of them is prevent. Of course, the medical meaning is reduces the risk of outcome. And a common meaning is to completely stop outcome. Works, the medical meaning is a significant reduction in a bad outcome. The common meaning is completely effective. Safe, this is actually something I've stopped saying the phrase vaccines are safe because I think it confuses people. The medical meaning is a low risk of side effects and that the benefits outweigh the risks. And the common meaning is no risk of bad outcomes. So a lot of people, if you say vaccines are safe, they think that means it should have no side effects. And so instead, I usually try to frame it in a benefit risk framework instead of just safe or unsafe. Other words that confuse people, I mentioned this before, but I stopped using the word misinformation except in academic settings like this right now, and in academic publications, but in all public communication, I've stopped using this word because it means different things to different people. So the intended meaning is inaccurate information. How a lot of people interpret it is information you're not allowed to question. And of course, if I start by saying, this rumor is misinformation, or this thing that RFK Jr. just said is misinformation, a lot of people are going to interpret that as you're not allowed to question what I'm about to say, and this is the truth, and I don't care what you have to say about it. So to a scientist, this is a vaccine that works. So we can see the unvaccinated in orange. This is US COVID deaths, vaccinated in purple. That is a dramatic reduction. We look at that and say this is super effective. But remember, the public was expecting 100% efficacy against death. And so they look at this and say, okay, these are vaccinated people who still died from COVID. That's not what I was promised. So lessons learned, sometimes odd rumors like the COVID vaccines aren't actually vaccines are signs of genuine confusion. In this case, it was confusion over what the word immunity actually means. And when possible, try to avoid words that have multiple meanings, like I mentioned, or if I know it's almost impossible. I'm not saying you can never use the word works again, but be sure to add clarification and think about how different people may interpret it. All right, so here's our second knowledge check. For each of the claims below, identify the words that are easily misinterpreted and may lead to miscommunication about vaccines. So the COVID vaccines aren't actually vaccines because they don't give you immunity. I caught COVID after getting vaccinated. They don't prevent you from getting sick. The flu vaccine doesn't work. Tons of people still catch it. So in the first sentence, immunity is the problem. People interpret that differently. Second sentence, prevent. Some people think that means reduce the risk. Some people think it means it's totally eliminating the risk. And then, of course, the word works. All right, lesson number 3. Shame does not work. So this is a cartoon from the New Yorker, I think from 2015. And if you read the caption, if you connect the measles, it spells out my parents are idiots. And this type of shame-based messaging is unfortunately, at least in the online world, a very common approach to vaccine hesitancy. Here's a couple headlines. Anti-vaxxers are stupid and contagious. Anti-vaccine debate proves you can't fix stupid. People think anti-vaxxers are stupid and selfish. And this rhetoric is incredibly common online. And it comes from a place of valid frustration, but unfortunately it's framing in a way that's unhelpful. So for me, it's helpful to think about this distinction between guilt and shame that kind of highlights the way not to do this in a more productive way to do this. So this is from Brene Brown. She's the one who really broke this down and explained it. So guilt is more focused on behavior. So guilt says something like, I've done something wrong. And shame is more focused on the person. So shame says it doesn't say I've done something wrong. It says I'm a bad person. Guilt says when you said that it was hurtful. It's focusing on a specific behavior and the outcome. Shame says you're mean and heartless in response to the same message. Guilt says not vaccinating increases the chance that you and those around you will get sick. That's a focus on the behavior and the outcome. Shame says anyone who doesn't get vaccinated is selfish and doesn't care about other people. That's now making a judgment about the whole person instead of focusing on the specific behavior and action. So overall, these focus on the behavior versus shame, which attacks the whole person. And we know that shame is an unhelpful approach, but unfortunately, it is very commonly used. So there was an analysis of TikTok videos that looked at both pro-vaccine and anti-vaccine videos, and the pro-vaccine videos used more negative language and judgment than the anti-vaccine videos. And we know that this was a study during the COVID vaccine rollout. Feeling morally reproached or morally judged for vaccination or not vaccinating was strongly associated with vaccine refusal. So this, I think the rationale behind the shame-based approach is if we make it socially unacceptable and make people feel, like they're bad people for not getting vaccinated, that will motivate them to change their behavior. In reality, it's the opposite. And this was a study of Twitter conversations that found negative or rude corrections of misinformation often backfired and further entrenched the recipient in their belief, versus more neutral or positive responses were far more effective. And I think the reason this is such a problem online is often those shame-based rants, sometimes by physicians and scientists, sometimes just by members of the public. They resonate with a lot of people because there's certainly a lot of valid frustration about all of the lies and rumors about vaccines. And so they go viral. And if you post something about vaccines and it goes viral, it can feel like you're helping because you're getting more people to see your message. But we know from this data that if someone who's truly vaccine hesitant sees that message, it's actually likely to do more harm than good. So what do we do instead? So first, fully acknowledge how frustrating the rise in vaccine hesitancy and mistrust is, and vent about it, but privately, not on the internet. And yeah, the rejection of evidence-based medicine in favor of anecdotes and memes is incredibly frustrating. But reacting out of anger out of anger to that frustration is itself not evidence-based. So don't respond to anger about people not following evidence-based medicine by doing something not evidence-based yourself. And what do we do instead? Connect over shared values. So messaging like this is from some news article. I can't remember exactly what. But messaging like this is common, but not effective. And instead, it's far more effective for people, if you're trying to connect with someone who's hesitant about vaccines, to connect over shared values instead. So this was a study where they put out an ad about the COVID vaccine on Facebook, and they used their A/B split test feature, so you can make two ads and see which one performs better. And on the left, they did an efficacy-focused message. So most COVID deaths are now among unvaccinated individuals. Vaccines work. Get yours now at your local pharmacy or doctor's office. So emphasizing that the vaccines are effective. On the right, they did an autonomy-focused message. So no one likes being forced to do anything. You have a choice. Most COVID deaths are among unvaccinated individuals. What do you choose? And the autonomy-focused message did better. And this is especially true now, I think, with the rise in the medical freedom movement and people highly valuing autonomy in their healthcare decisions. This was another study that just looked at the difference of letting people know the religious affiliation of the messenger. So the study, everything else was identical. It was a video about the COVID vaccines in a controlled online survey. And the only difference between the two study conditions was one version had Francis Collins share that he was a Christian, and it was at the beginning of the video interview in addition to in his biography. The other one did not. And it had a dramatic effect. This was a study specifically for American Christians. It had a dramatic effect on the trust that's in the bottom there, trust in the medical expert, and as well as a positive effect on vaccination intentions and willingness to encourage others to get vaccinated. So no difference in the facts that were shared or the strength of the argument about the vaccine. It was purely knowing that the messenger had that shared faith. This is a highly recommended TED Talk from Katharine Hayhoe. She's a climate scientist who's also an evangelical Christian. And she talks about how she shares messages about climate change and tailors them to the values of whoever she's talking to. And it's an amazing talk, and I highly recommend you watch it if you haven't already. All right, lessons learned: focus criticism on the data, not the person. And that shame does not work. Kindness does. And don't attack people who disagree about vaccines, but do connect over shared values whenever possible. And of course, it has to be genuine. Don't make things up. Don't pretend you value something if you don't. But wherever you can find connection, that's the best place to start. All right, knowledge check. Which of these statements avoids a shame-based approach to vaccine communication? I hope this one is easy and obvious. These were kind of painful, honestly, to write. So I hope you benefit from the pain that went into this question. Moms who send their kids to school unvaccinated don't care about other people's kids. Anti-vaxxers don't want vaccines, but then they come running to doctors when their kids end up sick. The decision to not vaccinate impacts not just you, but those around you. And I see someone thinks they know better than every pediatrician in the country. Of course, the answer is C. All right, lesson number 4. Don't confuse data and values. So this particularly came out when the COVID vaccine mandates were introduced. And what I was seeing over and over and over again is people were really angry about the mandates. And so they started attacking the efficacy of the vaccines. And what I wanted to be able to scream to people is, you can disagree with the mandate decision and still recognize that these vaccines work. Like, you don't have to, if you disagree with vaccines, that doesn't mean you have to attack the vaccine. Or sorry, if you disagree with mandates, that doesn't mean you have to attack the vaccine themselves. But this was a common logical error people were making, is feeling like, hey, I don't like that this was mandated, so my only recourse is to attack the vaccine itself. Unfortunately, the same mistake happened in reverse by some in the public health world, is that we saw these vaccines were super effective in reducing deaths. And so some of the messaging suggested that science says the vaccine mandates are the right decision. The problem with that is the decision around mandates wasn't purely an objective scientific one. So the objective data told us about the efficacy of the COVID vaccines, things like that they decrease the risk of death. But of course, policy decisions aren't purely based on objective data. They're also based on values and ethical decisions. So, and these are more subjective. So examples would be the value that protecting public health is more important than protecting an individual autonomy, or protecting individual liberty is more important than protecting healthcare capacity. So these are, of course, very important decisions and values and ethics that need to be weighed and debated, but they're not purely objective in the sense that we can't design a randomized controlled trial to answer the question, which is more important, life or liberty? Both of those things are very important, and they're going to be weighed differently by different people in different situations. And of course, policy combines both of these, and we need both of them. The problem occurs when the value system, such as life is more important than liberty, is treated as if it's an objective scientific fact. And in some of the messaging, this is kind of what happened. So instead of acknowledging that these policy decisions were both based on objective data and subjective value judgments, it was presented all as if it was the science, and science backed all of it. And of course, the more subjective, ethical, and values-driven part is not decided by the scientific method, and people recognize that. So what do we do instead? Recognize that those two things are distinct and be clear where the data ends and where ethical arguments and value systems and opinions begin. And be careful not to label the latter, excuse me, the latter half as something that science says. And if scientists mix their values, ethics, and opinions into the data and call it all science, then the public will view science as a matter of opinion. All right, last lesson, lesson number 5, is we need more trusted messengers. So I'm sure it comes to a surprise as no one that trust in institutions is declining. And I think this model represents how people, this is what I thought, how communication would go during the pandemic, is that we'd have our public health institutions, our national leaders putting out the messages, and people would listen. And this is more how it went, is that we had those messages. Sometimes they were great, sometimes they were confusing, sometimes they were late. But they were failing to reach a lot of people, and people were trying to find other sources of information, like their grad school friend or grad student friend on Facebook. So I think this is how it needs to go. Instead of this top-down approach where we're expecting kind of the health institutions and leaders to be the main ones communicating, now that information is so accessible and disseminated so rapidly on social media, we need more trusted messengers embedded in both physical and online communities that can rapidly and accurately share up-to-date information. So that means we just need more communicators. And so this is my call to action for you, is that this is you and your community, whether you're a clinician, this is you with your patients, or if you're a person who is either on social media or is interested in becoming on social media, this is something that's very much needed. And right now, we're kind of the voice of the accurate information is being drowned out by the inaccurate information online. I recently wrote about this in the New England Journal of Medicine, the need to train more health communicators, and the need to integrate training in this sort of online informal style of communication, integrating that into medical school and graduate schools and nursing schools and public health schools. So if you'd like, the QR code leads to that article. And of course, I was just, this presentation could have been made before RFK Jr. came along and changed things, but this has just put gasoline on the fire. The problems were there before he became HHS secretary, but the volume has just been turned up. So I wanted to spend the last few minutes telling you about just some trending rhetorical tricks about vaccines that I've seen circulating more in the last year or so a lot of them centering around what RFK Jr. has said. So the first one is rewriting germ theory. So I've not read his whole book, but I read part of it. And there he talks about germ theory and kind of laments that it's become the dominant position in modern medicine. And one clarification is it's not that he doesn't believe germs exists, but instead he doesn't seem to believe that they are the main driver of disease. So this is a quote from his book. When a starving African child succumbs to measles, the miasmist, which is what he seems to endorse, attributes the death to malnutrition. Germ theory proponents, aka virologists, blame the virus. The miasmist approach to public health is to boost individual immune response. And he talks a lot about nutrition and reducing exposure to environmental toxins. So the rhetorical trick that is commonly being used is this setting up this false dichotomy between the impact of infectious disease and then more chronic factors like nutrition and environmental exposures. And the way RFK Jr. is setting it up is you have to pick one. You have to say either the infectious disease is to blame or nutrition is to blame. And in reality, we know often both are playing a big role. And so in the case of the starving African child, we need to both address the malnutrition and address the measles. We don't have to pick one or the other. But the way he sets up this frame, the knee-jerk reaction is to emphasize the role of the infectious disease and not emphasize the role of nutrition when it's appropriate. And that lets him kind of go along with his narrative that doctors don't actually care about nutrition, which is, of course, not true. So the solution, don't fall for the rhetorical trap. Whenever you can, emphasize the importance of nutrition, environmental factors, as well as things like vaccines. We don't have to let him push us into a corner of only picking one. We get to pick all of them. The next one I've seen trending is redefining what informed consent is. So this is a very simplified version of what informed consent actually is, which is expert recommendation based on clinical context and evidence, and then the explanation of the risks and benefits in an understandable language to the patient. And then the patient has an option to ask questions and then ultimately makes a decision. So it's being redefined where it's sort of eliminating the importance of the initial expert recommendation. And instead, it seems to be wanting to give people a giant list of risks and benefits, and then the patient is expected to do their own research and figure out what's best for them, and then they decide. So the rhetorical trick that's happening is implying that expert recommendations infringe on personal autonomy. And of course, that's certainly not our intention when going through the process of informed consent. So the solution when you're coming up against this type of rhetoric is to emphasize the role of experts in empowering people to make health decisions by being a resource to explain the data and answer questions. So it's not that experts are just telling everybody what to do and then they have to do it, but that we're there to be a resource and to empower them and to help them make decisions that work for their lives. So this is my last slide. I just want to end with this. And it's a reminder that while we are seeing this rise of, or decreased trust in vaccines and then rise of this rhetoric against vaccines online, there's still a lot of people who are just confused and who just don't know what to believe because they're getting so many conflicting messages. So this was the data from this summer, July and August of 2025. Few parents say they think false statements about vaccines and measles are true, but at least 4 in 10 express uncertainty. So if we look at the top one, chronic disease are likely rising because of an increase in the number of vaccines children get. 13% say that's true, 45% say it's false, and then 41% say they don't know enough to say. So those are the people we need to reach. Those are the people who are just not finding a good source of information to answer their questions. It's not like they're totally against vaccines, but they're just confused by what they're hearing. So there's still a huge window to reach a lot of people who have genuine questions. And I just wanted to acknowledge Caitlin Gentilina. I work with her, one of the contributing writers for Your Local Epidemiologist. A lot of the content you saw today started as a series I wrote on her newsletter last October, and her insights have been invaluable in kind of reflecting and learning these communication lessons. All right, with that, I'll take any questions.
Thank you, Dr. Panthagani, for an incredible presentation. Okay, I do believe we have a couple of minutes here for questions. We had so many that rolled in. I think a nice segue, because you were just ending on this, was someone asked, where do you suggest that us as health communicators get our information with the infrastructure collapsing for finding and verifying scientific evidence?
That is a great question. I don't know that I have a simple answer. Um, so I think it depends on specifically what we're talking about, of course. Right now, from what I've seen, some of the information on our traditionally trusted sources like the CDC is still accurate, but there's obviously the concern that some of the information is disappearing and that some of it may be changed. Um, I think it's a major need that needs to be filled. I don't know that I have a simple, like, here's where you go. It's going to be a conglomerate of sources, university websites, the original literature. I think people, like, sort of in doing this more informal style of communication is going to be more important than ever to get that information out, because some of our traditionally trusted sources, I think, are going to become less reliable. So I'm sorry for that sort of non-answer answer, because it's
No,
a very hard
I
problem
really
and I don't have an easy answer.
I really appreciate it. I'll just share, as both a practicing physician and the medical director here, we often actually point people to places like your newsletter and Caitlin Jelina's newsletter. I also often point people to the medical societies, so the American Academy of Pediatrics, ACOG, AISD, etc. We've been pleased to see alt groups kind of standing up in this arena too, like the Vaccine Integrity Project and some of those others. So I do think this is maybe a moving target of a field, but I really appreciate the question, and I think you answered how we all feel. So, okay, maybe a couple more if you're willing. Someone asked, what would be your top 2 to 3 recommendations for healthcare personnel to help frame immunization content for the public? So, for example, websites, social media, etc.
Uh, okay, I guess I don't know if I can ask a follow-up question. Is this communication to the public like in a online setting, or is this one-on-one with patients?
I think so. Yeah, I think they're saying, what would you be some recommendations from you for healthcare personnel or maybe vaccine experts who try to help frame immunization content or healthcare content for the public? Yeah, probably in social media or websites.
Okay. Yeah. Man, there's a lot of different angles to this. I think one of the biggest challenges that we're seeing right now is that the the style of communication that we're all trained in as academics is not the style of communication that works online. And in a lot of ways, we have to sort of untrain ourselves to have the professional tone and keep our personal lives completely out of it. And instead, what works online is um, being being a real person that's like sometimes shares some of their personal life, brings storytelling into it, brings that emotional component into it, which is something I'm still learning to do. It's very hard. Like, we're trained to not use anecdotes, but anecdotes are what are really compelling. And so learning to make that transition if you're trying to communicate online, I think is going to be the biggest challenge and the most important hurdle for us to overcome, is learning like what really resonates online. And it's being an authentic human being, not being the person just in the suit that's a talking head, and weaving in the evidence-based medicine with storytelling and compelling content. So that's easier said than done, but I think recognizing it as, just the lecture style like we're doing right now, that just doesn't work online.
Yeah, I really appreciate that answer. You've probably seen there's poll data to say that while people are losing trust in government agencies or maybe even public health, entities, people do still trust their individual providers
Yeah,
highly, and nurses actually are highly
yeah,
trusted. So being
absolutely.
able to do that in that space is very important. This one is a little bit more maybe in the clinic visit, so kind of along the same vein here. This commenter said, I really appreciate the content you shared. I struggle to find the sweet spot in vaccine communication because of the seemingly conflicting research from pre-COVID times that shows language that isn't strong or includes qualifiers leads to a decreased trust in the general public. How do we ensure we're providing straightforward, confident language that is also accurate and doesn't overrepresent what the vaccines will do? Kind of a mouthful, but I know what they're getting at. I think here at CERI,
Yeah.
we used to teach about like the presumptive method. And I don't know, curious to hear your thoughts about that.
Yeah, that's a great question. And I think maybe part of that is what works in a one-on-one visit. Like that's a different, totally different communication environment than like public messaging. Because in the one-on-one visit, you get to read their response, you get to understand what their specific confusion is, you get to answer follow-up questions. So that is separate than putting out a message on, either a press release or a video or something, where you have to have one message that kind of works for everybody, which is never the case. It never actually works for everybody, but you have to try. So I would say, I don't know that I have a definitive answer to that question. I think gauging what works for the individual, and I think in particular, if you have somebody in your office who's very on the like medical freedom side, autonomy side, that some of the traditional methods may not be as effective. And that just sort of I'm the expert and this is what I say to do can really backfire for that group. But it may be that the methods that you've been using for somebody who's just like, I don't really know, are still going to work.
Hmm. Yeah, fantastic. We do very similar teaching here about, people are on a spectrum of either hesitancy or acceptance and trying to kind of locate where they are and then tailoring your message to that, especially one-on-one visit. There's not a one size fits all when it comes to vaccine acceptance for sure. Okay, I don't want to take too much of your time. Maybe we'll just do one more. There are so many questions pouring in. Feel free to choose one if you're seeing them too, but I kind of liked this question maybe to end. Are you concerned that as healthcare professionals, we are normalizing vaccine hesitancy the more we talk about it?
Uh, that that's a great question. I guess I think the answer is no. And the reason why is people we're not the ones generating this. Like it's not that people are hesitant about vaccines because doctors are talking about it too much. People are hesitant about vaccines because there is so much content circulating online about that's sowing distrust in vaccines, or that's, I guess, a big part of it. So if we stop talking about it, that's not going to go away. So I think it's important to acknowledge that people have questions, and I think framing it as people having questions instead of, a lot of people don't trust vaccines. Say a lot of people have questions about vaccines is one way we can kind of shift the concern that's being addressed is that, we're talking if we talk about it so much that all these people distrust vaccines, then maybe people are like, I should distrust them too. So I think we can address it without fueling it by just acknowledging that people have questions, and that's fine.
I really appreciate that answer. I think too, maybe not framing it as a debate, like
Yeah.
trying to not give legitimacy to that this is a
Yeah.
debatable thing, but exactly as you said, that reframing it as people having questions. So, well, I just want to thank you again on everyone on behalf of Siri, and thank you all for joining us today. We look forward to seeing you again at our next webinar. Have a great week.
Thanks, everyone.